Evening, Doc. How are you?
I'm fine. Prof, are you on now? We'll start at exactly 5 o'clock. Do you hear me?
I can hear you.
Oh, okay. Thank you, Dr. Vicky.
All right.
Prof, can you hear me? Prof. Laalou?
Hello.
Hello, Prof. We can hear you.
Yes, do you hear me?
Yes, we can hear you.
Okay. Do I have to share my screen?
So we'll ask you to share just now. We just want to introduce you so that everyone knows who you are. So we'll introduce you shortly.
Let me try the share of the screen.
That's fine. Dr. Hama, you can proceed.
Okay. Yeah, Prof, we can see your screen now.
Okay.
Yeah. Let me introduce you to the Zimbabwe Dental Association. Good afternoon, colleagues. Today we are continuing with our lectures for virtual annual congress for 2021. We are excited today to introduce Prof. Younès Laalou from France. He is a distinguished expert in implantology. His CV is very impressive. He has got a lot of master's degree in dental biomaterials, in fixed prosthodontics, removable dentures from the University of Paris, and master's in periodontology. He's also a founder and the director of FCI training and education in implantology and advanced implant surgery. Today's topic is immediate implants with zero bone loss technique. We are going to have this lecture now. It might take 2 hours like yesterday, but after an hour, we will take a break if there is any need. And if anyone has got questions, we will be glad to have them. You type in the chat box. When we take a break, we'll answer a few questions, and then we continue. Now I will hand you over to Prof. Laalou. Prof, you can go ahead.
Thank you very much. You hear me? It's no problem.
Yes, I can hear you.
Okay, I would like to thank you for your invitation and to thank the organizing committee of the Zimbabwe Dental Meeting for inviting me. I first must apologize for my English. We are used to lecture in French language. I try my best to get the message done for you. As you said, I'm not from France. I'm from Morocco. I lecture in Morocco and I practice in Casablanca, Morocco. Do you have the slides? Do you have the slides in the screen?
Yes. Yes, we have the slides.
Full screen?
No, not yet full screen.
I don't know how to do it.
Click where it says from beginning, Prof. If you go to the top left hand of your screen and click from beginning, we'll get a full screen.
I get to the
Top left.
top left
Top
for
left.
what? Of my PowerPoint?
Of your desktop, yes, where it says from beginning under file.
Open your PowerPoint.
Okay,
yeah.
okay, okay.
Yes,
That's it.
exactly.
Okay, I forgot
Full
it.
screen now.
Thank
Yes.
you. Thank you very much. Okay, the topic today is about the immediate implant with the zero bone loss technique, which is a technique I developed in my practice, but I didn't publish yet. As we know now, excuse me, I have a problem. Okay, voilà. As we know now, the extraction and immediate implantation is now a reliable and predictable technique. It has been a long time now that I practice this technique, and I'm very happy with this technique because we have all over the world very nice results. There are many biological and anatomical advantages of this technique. You have less surgical interventions and less bone resorption, preservation of soft tissue volumes and profiles, that we keep the papilla and the keratinized gingiva around the crown and the implants, which enhances the aesthetic, especially in the aesthetic zone. The bone of the freshly extracted socket is dense, and this is a good advantage because it helps to get a very good primer stability of the implant. And in the case of full arch rehabilitation, we can keep the shape of the dentate arch as normally, and we can achieve very good aesthetics. When you do the extraction and immediate implantation, you may avoid in centered cases additional techniques such as sinus lifts or grafts. Excuse me. But we must know that we have some limitations, as the difficulty in obtaining complete coverage of the implant site with soft tissue, especially in the molar region. Difficulty in achieving good primary stability, because in some cases the socket is too wide, too large, and we cannot put the implant. But I must tell you that in the anterior zone, we can implant whatever the socket is. This difficulty is often encountered in the posterior region, especially in the molar region, in the lower maxilla. You must also have some technique managing the space between the implant and the alveolar bone. There is a great risk, big risk of infectious complications. And you need flap to cover the implant if you have a two-stage surgery planned. There's also a risk of partial resorption of one or more alveolar walls due to the pathological process or damage during the extraction. So you need some skills to get over these difficulties. So it is a technique. It is a technique that is very sensitive, and to get started for the beginners, there's some roots. You have to have roots without periapical infection, preservation of the remaining bone during the extraction, and you have to have at least 4 millimeters of residual bone at the apical zone. You must have also favorable gingival contour to achieve good aesthetics, especially in the anterior region. And you must have buccal bone preserved after extraction. This is the minimum to get started. I advise my students not to get started with difficult cases, because if you have a difficulty that you cannot manage, you have very bad results. You have very bad aesthetics, and you can lose your implants also. Let me start with a reminder of the anatomy of the sockets and the alveolar bone and the post-extraction healing process. If you start doing extraction and implantation in the anterior zone, you must have some basic knowledge about the anatomy of the bone, the bone in the buccal bone in the anterior region. The average height of the vestibular bone at the anterior central incisor is 1 millimeter. 1 millimeter, according to Nozari, from 1 to 10 millimeters of the height from the border of the bone, the cervical region to the apex. According to other studies, we have 1.4 millimeters to 1 millimeters, and according to Katbrenji, who did a cadaver study, we have 1.6 millimeters to 3 millimeters. But in most cases, we have very thin bone in the anterior region, and you can see it on some CT scan images like this. You have very thin bone, and this bone is very weak. You can break it during the extraction, and the extraction must be very careful to preserve the buccal bone. In from one out of 3 cases, we have fenestrations and dehiscence of bone in the anterior region. So you have 70%, almost 70% of intact bone. But you must know that one out of 3 cases, we have this kind of dehiscences or fenestrations, and you must be aware of that in the beginning. So I advise in most cases to raise a flap to see if we have this kind of fenestrations or dehiscences that we can, in order to deal with it properly. In some cases, we have a very particular anatomy, as you see in this case, and this is a central incisor, and you have a very narrowing bone in the apical region. If you do the extraction without knowing this, you go through very big problems. So I must emphasize on the necessity of doing in some cases a CT scan images, so we can have a three-dimensional approach of the anatomy of the patient. In the chronology of alveolar bone healing is, if you don't do the extraction, you must wait in average 4 months. This is the beginning of the extraction, the T0, the day of the extraction, and you have complete healing, almost complete healing in best cases at 4 months. And if you put your implant, you must wait 2 months before putting the crown on the implant. So it is very interesting to extract and to implant at the same time. It saves us at least 4 months of healing. One other question I ask is, it is necessary to systematically fill in case of bone loss. In most cases, we in conferences and publications, the authors advise to fill the extraction socket with bone with grafts, otherwise it is allografts, xenografts, or synthetic bone. I usually don't advise this to my students because I let the nature do its work. As we see in this case, this is the case before at the extraction, the day of extraction, very large defect, but in the as we less time do this, the healing takes place, and we don't have to fill anything. You have just to wait 4 months before doing your implants. This is another case, but there's a huge infection, acute infection. This is an abscess, and you see the extract after the 4 months, or this may take more time, maybe 6 months, but at the end we have nice bone to implant without filling. Let's see this case where the central incisor must have to be extracted, and as you see, you have gingival recession. If you implant immediately, you have to manage this gingival recession. In some cases, it is better to do the extraction and wait, temporize. This is a bonded bridge, bonded temporary bridge done to the patient. And as you see in the X-rays, this is the day of the extraction, very huge defect. And this is 4 or 6 months, I don't remember. This is 4 to 6 months after extraction. And the implant was inserted and the crown done. As you see, this is the image before and the image after the cementation of the crown. There was a recovery of gingiva without doing anything. There was no bone filling in this case. It's just time and nature who does its work. This is a very huge infection in a female patient, which has a very huge infection with, as you see, very large defect. In this case, I don't advise to do a filling, because if you do a filling in this case of infection, you may have a very huge infection and more bone loss. This is just a simple extraction with curettage of the socket. And as you see, the progression of the healing of the bone is very nice at 6 months. This is at 4 or 3 months, and this is at 6 months. As you see, the implant was inserted and the crown done. And this is those are the images of the healing after 6 months. As you see, there was no big defects in this case, and there is no special feelings, no problem with that. As you see, the day of the insertion of the crown, it is a very nice results. This is the day of the insertion of the crown. I didn't see the patient from that day. This is a case I did at least 6 years ago, but I have never seen the patient to do another photo of the site. But I'm sure that the papilla got in the embrasure here, and you have a very nice results. This is a classification of the type of sockets after extractions. I don't remember the author of this classification. I took it from somewhere, publication, but I don't remember the author. I apologize for that. We can classify the extraction sites in 3 types. The first type is the most easy case, when you have vestibular alveolar bone intact. This is the case with no gingival recession, and this is the situation we have. It is very ideal situation for extraction and immediate implantation. The type 2 is the vestibular alveolar bone that is absent without gingival recession. You have an absence of bone here, but you don't have any gingival recession. This case is less favorable, is unfavorable for extraction implantation in the aesthetic zone. And the type 3 is loss of the alveolar table with gingival recession that is very unfavorable for implantation in the aesthetic zone. This is what we have in the literature. And if you want to get started with extraction and implantation in the aesthetic zone, you must deal with this type of anatomy. You have to have your bone in the vestibular zone, and you have to have no gingival recession to achieve good aesthetics. This is the ideal situation for immediate implantation, especially for beginners. In my lecture, I will deal with the 2 types, the type 2 and the type 3. I will show you how to extract an implant in the type 2 and type 3 zones. That is when you have less bone, you have lack of bone in the vestibular region, and you have no gingival recession, or the type 3 where you have a loss of bone in the vestibular aspect and gingival recession. That is the aim of my conference. This graph summers up what I have just said now. The type 1 socket with no bone loss, no soft tissue loss, and you have thick gingival biotype or thin gingival biotype. You can do your immediate placement of implants, and you can have less than 2 millimeters of buccal bone, and and you must put your implants 1 millimeter subcrystal. You can do a fill-in with immediate temporary crown if primary stability is more than, you achieve more than 35 Newton centimeters, that you can have immediate loading. If you have thin gingival biotype, excuse me, you can do your immediate placement, and it is advised to delay temporary crowns to 3 to 4 months in order to achieve good aesthetics, because you go through a 2-stage surgery. And the other types, socket type 2 and type 3, it is advised not to do immediate implant placement. As I said in my previously, I will deal with these 2 types of anatomy. One thing, that the walls of the post-extraction alveolar are dense. That means that you can achieve better primary stability. And this dense bone will have a limitation. This have an inconvenient, short, what we call short, the inconvenient. I don't know how to do it in English. You can have the implant pushed forward by the opposite side of the socket. I will explain this notion very deeply in the following slides. Another thing to have in mind, that the implant axis is rarely the same as the alveolar axis. In most cases, the axis is very buccal of the root, and we have to do drilling parallel to the palatal wall, because it is very difficult to achieve this kind of drilling. Let me explain this. This is the drilling axis without correction of the axis. When you drill in the same axis of the socket, you may have in most cases a very thin bone in the apical zone, and you get too near to the alveolar bone in the vestibula. And if you do an overcorrection, I will see it in the following slides. Now, if you continue your drilling without seeing and without raising a flap, you have a very very inclined axis of the implant, and you have very thin bone left in the buccal side. This is this bone will resolve in a few months, and you have a very bad aesthetics. You have a gingival recession and bone resorption, and your implant will be visible through the gum in the anterior region. This is very anesthetic. If you do a correction of the axis, you must incline your drills so in order to be parallel to the palatal wall. But if you do overcorrection, it is not nice, because when you put your implant, the implant is maybe pushed forward, and you have a very inclined implant in the vestibular zone. This after this, you have to deal with a very thin bone also, because your implant has pushed your bone forward, and you have very bad aesthetics in the aesthetic zone. The classical approach advised to use a round burr or a pilot drill. parallel to the bone, the palatal bone, and you must be very careful to get this in this direction, very parallel, not overcorrected, because as I said, you may have your implant inclined during the insertion, during the late phase of the insertion. After that, you have to do your normal drilling, following the drilling normally. In this case, you have your implant that is very lean to the palatal bone, and you have to have this gap. It is normal to have this gap between the alveolar bone, the buccal bone, and the implant. It is advised to have at least 2 millimeters. These millimeters will anticipate the resorption of the bone. You must also have your implant, the drawing here is not correct, but you must have your implant put at least 1 to 2 millimeters apical to the border, to the cervical bone in the palatal region, as to anticipate resorption. Let me show you this case where it is there's a immediate implant here. This is the buccal side, and if we, as you see, the implant during insertion has been pushed forward here. Pushed forward the buccal bone. If you anticipate the resorption around this implant, you will have resorption here, and you have gingival recession and bad aesthetics. This is the correction that you must use for correcting this axis, what we call a trephine bone, bone trephine. I will show you how to use this bone trephine. You get a carat of bone, and then you do your normal drilling, inclined or lean to the palatal wall. As you see, there's a huge difference between this implant and this implant. This implant, as you see, the implant is put palatally is here, and we leave a gap here that we can feel. It is better to have it in the palatal aspect and not to have it in this is the implant, as we should do it in the anterior zone. This is for a lateral incisor here, and the implant would be will be covered with gum. As you see, the carrot here is put between the implant and the alveolar bone to fill this gap. And the site is covered with the sutures. Let me explain this through this case, difficulty to have that I explained. This is the implant that is pushed forward the weakest wall, proximal wall. This is a patient, woman patient, who came after to my practice after having an implant 4 months ago, and this what she complains about, soreness here and infection. As we do the X-ray, we see that we have a very big defect in around the implant, and the implant has been put too near the root of the lateral incisor. After raising the flap, you see that the implant is not covered with the heel bone. This is granulomatous tissue or soft tissue that is infected, and you have no bone in the buccal aspect, buccal wall. no bone in the proximal region, and no bone in the palatal region. The implant is obviously not working, and I screwed it out, and I have, as you see, a very big defect. That is, if we go to the first slide here, you see that the dentist who put the implant without raising a flap immediately after extraction, and he put, in my opinion, a very wide implant. This is too wide for the socket, and during the insertion of the implant, the most powerful bone pushed the implant toward the weakest bone, that is vestibular and buccally, and proximally to that is why we have this kind of problem. That is why I stress upon getting a good access of implantation by doing what I call the zero bone loss technique. This is during curettage of the tissue, soft tissue, and you have a very large defect around the incisor and the central incisor and the lateral incisor. As you see, this is the axis of the central incisor. There were conversion to the apical region, and the dentist didn't deal correctly with that. As you see, this is the case after extraction. Very bad lesion here, and very bad results. Let me explain I will explain through this case. This is the correction of the axis of the implant. This is a central incisor with internal resorption. This central incisor have to be extracted. We notice let me show you the axis of the root, which goes distally. It is not in the same axis of it should be, because of the lack of the lateral incisor. In this case, he had a sort of agenesis of the lateral incisor. After extraction, as you see, we don't have any buccal bone left. The axis is very inclined to the proximal distally, and we have to correct that. In order to correct this, you can use the classical approach with a pilot drill, or as I do in my technique, trephine, a bone trephine, to get a new socket. This is the socket, the socket of the extraction, and you have a new socket here. The parallel pin to control the axis of the implant, and you do your normal drilling of the apical region. You must have at least 4 to 5 millimeters in the apical region. This is normal drilling, the sequence drilling from the thinner to the wider drill until you get to your implant. As you see, the implant here is uncovered. We have a very huge defect around the implant distally and buccally. What we in this case, you had to have a filling with what we harvested during the extraction with the trephine, the bone trephine, and with alloplastic graft. And in this case, it is advised to cover the site with totally with to do a 2-stage surgery. A frenectomy was done at the same time, to get a free flap and to cover correctly the site. This is the X-ray immediately after implantation, and this is the case after 6 months healing. As you see, there was a very nice recovery of the gum. We have no recession, and there is no bone loss around the implant. The implant is here, and this lateral incisors is cantilevered on the crown, on this lateral incisor. The X-ray, the control X-ray, here we have no bone loss distally, and you have no bone loss in the buccal aspect. One important thing to note that what we believed in 20 years ago, we believe that by doing immediate implant, we can prevent the process of resorption. This was a very false idea. This is not true, because when you do your implant immediate implant, you must know that this does not prevent the resorption process. The process will go on. The process of resorption will go on. You have to anticipate it, as I said previously, by doing the insertion of the implant the most palatally possible you can have, and let the buccal aspect here at least 2 millimeters here. There is another thing to know, that you must not fill the socket with the implant. The more metal you have, the more implant you have, the less you have, the less bone you have, then the less gingiva you have. And when the resorption will happen, you have a very bad defect. You have very bad recession of the bone and the gum. You must choose a very thin implant, that is the standard diameter of implants, that is between 3.5 to 4 millimeters in the utmost, the most wider diameter mustn't be more than 4 millimeters. The placement of the implant must take this into account. The diameter of the implant must not be related to the extracted tooth. The tooth may be wide, but the implant can be less wide. You can use, as I said, a standard implant 4 millimeters at best. This is the image for explaining what I said. The implant must be aligned to the palatally here, and you leave this defect here. Your implant must not be put forward, not toward the buccal aspect. If you have this kind of defect, you must fill it. Otherwise, with the bone harvested from the patient, or a graft. So in the aesthetic zone, now I go to the zero bone loss technique. For doing this zero bone loss technique, you must use a bone trephine, that is, bone trephine that is 3 millimeters or 4 millimeters in diameter, that you use at 1,000 to 2,000 revolution per minute with irrigation. And we use bone drilling. After that, we use bone drilling with the normal drills without irrigation at 70 to 100 RPM. when you do your in most universities and most courses and most publications, you have drilling done with irrigation. This is normal because with high speed you have heating. You have heating of the bone. It is very bad for the bone process of the healing. But I personally do bone drilling without irrigation. You have two conditions to do your bone drilling without irrigation. Three conditions. You must use very sharp drills, not too much used drills. Sharp drills, very low speed, as I said, from 70 to 100 RPM without irrigation, and a high torque. You must use at least 50 to 59 Newton centimeters in the motor and the electrical motor for insertion. As you see here, for 80 RPM and high torque. This allows you to drill the bone nicely without doing irrigation. In this case, you can recover a very good quantity of bone. This is a nice bone that you can do for filling immediately for your patient. I explain about the bone trephine. The bone trephine is an instrument which gives you the possibility to have a carat of bone. There is an inner diameter that is, in this case, the 2 millimeter inner diameter for an outer diameter of 3 millimeters. This is a 4 diameter trephine burr, and this is a 5 millimeters diameter trephine burr. In most cases, you need only the 3 millimeters and the 4 millimeters in the interior region to have a new axis for your implant. And the harvested bone, as you see, as I said previously in the beginning of my lecture, the harvested bone can be used in the case of dehiscences and to fill the lack of bone around the implants. This kind of technique with the trephine, the bone trephine, can give you control of the implant axis, allows you to recover bone for a possible filling, and allows to recover of the drilling. Maybe in some cases where you have difficulties to have an axis, a correct axis, it allows you to recover the best axis. As you see here, you have a carat of bone that you recover, and you can put it in the saline solution during the intervention. After wait for the implant to be inside, and use the bone to fill the gap between the implant and the buccal bone. As you see in this slide, this is the axis of, this is how we can recover a good axis, because in most cases when you do your drilling normally without this trephine burr, the drills go according to the axis of the. It is very difficult to correct the axis. These trephine burrs allow you to recover another axis, a new axis, a better axis, a correct axis to insert your implant. With this drawings, I will show you how how I do my drilling with the trephine burr here. As you see, this axis of the socket of the extraction, and we create a new bone socket here with recovery of carotid bone. After that, you have to prepare the 4 to 5 millimeters in the apical region to achieve your primary stability of the implant. This is the sequence of the drilling and the insertion of the implant, as I said in a previous slide. And you use your carotid bone to fill the gap between the implant and the buccal bone. Let me go through one case to show this technique. This is central incisor that must be extracted because of fracture of the roots. This is the CT scan image where you have absence of the bone buccally here around the root. And if you do your surgery without raising a flap, you can go through some problems here because, as you see, as I raise the flap here, you have a very large defect in the vestibular bone. This is the technique, as I said. You use your trephine burr to create a new axis palatally, and you forget about the vestibular socket left by the extraction of the root. Here we recover the carrot, and as you see, this is a 3.6 millimeter diameter implant. You have very more than 3 millimeters of gap between the implant and the buccal bone that is filled with the carrot I harvested during the drilling with the trephine burr. The gap is too large, and we need. I did a graft with allografts here, and the implant was completely carved to wait for the healing of 3 to 4 months healing before second surgery. This is another case with the central incisor to be extracted because of internal resorption, apical resorption after orthodontic therapy. And here I didn't raise a flap, but it is the same technique. You see the socket of the root, and here the drilling of the carrot here, the bone carrot, and you see the new socket created by this trephine burr. And this is the case of drilling without irrigation. We harvest bone by this technique, and it allow us to put the implant and fill the gap between the implant and the vestibular aspect of the bone. This is the bone harvested during the drilling, and no, in this case, I didn't do any more grafts with any other material. The insertion of the implant, as you see, with very high torque, I can manage to do a mediate implant. This is the impression of the implant, and this implant, you see the axis, the good axis of insertion of the implant, and this X-ray. I remind you of the necessity to have it 3 millimeter apical according to enamel gingival junction here, and you must preserve the proximal bone in order to preserve the papilla. This is normal sutures around the healing abutments, and this implant is done with the one-stage surgery. This is the temporary bonded bridge to allow the patient to go with anesthetic replacement of temporarily with a temporary provisional incisor. After healing, this is a 2 or 3 months healing. As you see, the gum is preserved, the papilla is present, and you have a very nice results without any recession around the implant. Another case where there was a perforation here because of bad access, and the incisor mask had to be extracted. The same technique, you have a very large defect on the vestibular aspect because during the extraction there was a fracture of the bone buccally here, and this, as you see, the implant was put, and you have very at least half of the height of the implant uncovered. This is the caries that we recovered from the drilling, the trepanning of the bone, and this is the piece of bone that stayed attached to the root during extraction. You put it on this is the first thing you must do. You recover it from the root of the extraction, and we put it on the implant, and we reinforce that with the graft in the buccal aspect, and we let this for healing for 3 to 4 months healing. After healing, as you see here, you have bone around the implant and no recession, no resorption around the implant. This is at the time of insertion, and this is 4 months later. As you see, the bone was recovered here. No problem with that. I will show you through the advantages of using a trephine burr inside instead of normal drilling. This is a premolar. This is after extraction. As you see, there was a large dehiscence around the vestibular root of the premolar. The implant is put in between the two roots. This is the first premolar, and the carrot that was harvested during the drilling that is put in place here. As you see, it fits very well in this socket left by the vestibular root of the premolar. The implant, as you see, is put in the middle between the two roots in this premolar region. And you see the advantages of using autograft. This is an autograft for the patient without using any other grafts, the artificial grafts. Another case where we have to extract the canine, which had an ankylosis with the bone. The previous dentist had tried to extract it, but didn't succeed, and he sent it to our office. The extraction was done, and as you see, very large defect because of the fracture of the bone around the root of the canine. This is not bad, no problem. This is not a big problem. You you can recover this, as you will see in the next slides. You leave your root sterile. This is a forceps. You should take it with the forceps and then try to recover the buccal bone from the root. This is the buccal bone recovered from the root, and this is the 2 carrots that we recovered during the drilling of the 2 implants to replace a canine and the first premolar. As you see, very large defects around the implants that we fill with the bone recovered from the drilling and the bone recovered from the alveolar aspect after the extraction. This is enough to recover the bone and to have bone sufficient. This is in the buccal aspect. This is the image before and 7 years later. This is the canine. This is the premolar. You have no recession, no bone loss here, and this is the image of the CT scan of the patient, and you have bone in the vestibular zone, no recession, no problem with that. Only with the autograph of the patient himself. This is a case with periodontal defect, and we had to extract the 3 incisors here, the 2 central incisors and the lateral incisor, because of very bad resorption around these roots. As you see in this, this is what I stressed in the beginning of my lecture. You can have very particular bone here with very narrow bone here in this around this central incisor. Let me show you also this particular bone here, very narrow bone between you have almost the palatal, the lingual, and the vestibular bone stick together. You don't have enough width to do ear implants. And in this case, I will show you the video. Last technique. Okay. Do you see the video? Hello? Do you have the video here?
Yes, it's not yet playing.
It's not yet playing.
You can restart it.
Restart it. I'm sorry, it does not start. It's okay. I have problems starting my video. Hamza, j'ai un problème. Le problème, c'est que I'm getting help to get this started.
Okay.
Okay. Voilà. Attends, quand je le mets en plein écran, il ne marche pas.
C'est-à-dire que ça ne veut pas débuter.
Let's go. Okay. Do you have it here?
Yes, we have it.
Okay,
But
it's in
the picture
progression.
is still. Yeah, it's
So
now
this is
going.
it starts. So after extraction, in this case, I raise the flap, full flap with lateral incisions, because I'm expecting a very large defect and very narrow bone around the implant. The treatment planning was to put 2 implants, one in each of the in central incisors, and to get a bridge with the lateral incisor, the right lateral incisor, cantilevered on the bridge on the implants of the 2 central incisors. This is a full flap. I'm preparing for the grafts. There was it will be an immediate implantation with grafting of the vestibular bone around the central incisor. I must stress about the very nice curtage of the alveolar bone. You must leave anything. You have to have the good bone for implantation. This is the apex, as you saw on the CT scan. There were no not enough bone in the apex because of the periodontal problems. This is, as you see here, the drilling without irrigation. As you see the drill turning on without irrigation at very low speed. This is for the direction. The other central incisor. This is a pilot drill. I will go faster here. This is drilling without the pilot drill with 2 millimeter drill. As you see, you have this perforation. It was expected because we have very narrow buccal plate. Checking the direction of the 2 central incisors. And after that, we do expansion. Those are expanders, bone expanders, that you can do manually or with a wrench. We use this in the case of very narrow ridges. This is a classical expansion technique, in order not to do the normal drilling, but because if you do the normal drilling, you will lose all the bone buccally and you have very large defects. This is expansion through progression of expanders of large diameter, 2 millimeter diameter, and then the 3 millimeter, and you finally do the 3.4 millimeter before inserting the implant, that is a 3.6 millimeters. As you see, the bone is not very dense. I can do it manually, but if you have very dense bone, you do it with a wrench. You allow the bone to expand for 3 minutes before inserting the following diameter. I go faster to show you. This is with the wrench because it became very resistant. Then this is expanding the bone. As you saw on the CT scan, it was very narrow crest. And the insertion of the implant without any further drilling in this case. In this case, I didn't use the trephine burr. I did only the normal drilling without irrigation and expansion. Besides the expansion, you have to have a graft buccal. This is the insertion of the implant, correcting the axis during the insertion. And you have the bone that breaks. There's a fracture of the buccal bone. There's no problem with that. I will deal with that with the graft. And of course, it was intended to be a two-stage surgery. You have a very large defect here. What we deal with GBR. This is a collagen membrane that will be fixed with tacks, with pins. It is very difficult to stabilize this kind of membranes. And you must every time get it fixed in order to have a very good bone formation around your implants. Those are tags. The first one, and at the apical region. This is a kind of sausage technique that was described by Urban, but I have modified it because Urban mixed bone, normal bone, 50% of patient bone with xenograft, bioos. In most of the cases, you don't have enough bone harvested from the patient. And I usually mixed 50% of allograft with 50% with other beta TCP or xenograft as bioos. Now the filling is done with this mixture of graft. And you must overfill because you expect some resorption of this grafts after 4 to 6 months healing, and the membrane must be fixed, must be stabilized with tacks or pins. It is hammered in place. Okay. This is a 3 millimeter pin. It's okay. Now you have the collagen membrane, and you suture full flap. You have it. It's okay. This is the end of the intervention. And it is intended to be a two-stage surgery. Now I go back to the slide to see. Okay. Video. This is the case. As you see, there are large dehiscence here and very large defect. As you see, the fracture of bone during the expansion and insertion of the implant. This is not a problem, as I said, because we do GBR here, and we allow this to heal for six months. The X-rays with the tags here, the pins that fixate the fix. This is the image after 6 months healing, and you see a very nice recovery of bone around the implant. There's no more defect here. You see very nice. We have here at least 3 millimeters of newly formed bone. You see before and after extraction and after bone regeneration. This is after healing, a very nice result with this case. Do we have to stop for the break now, or must I continue? Hello? Can you hear me?
Hello, Prof.
Do you have our breaks, the break now, or must I continue?
I think we can take a maybe we can just take a short break in case. Can you hear me?
Yes.
We can take a short break in case you want to get water. Just a short break in case you want to get water or something.
Okay. Okay. How many?
Yeah. So
how much break?
Can we do like 3 minutes?
Okay.
Really short break, 3 minutes.
Okay. Okay. Okay.
Okay. So we'll start at 17 past again. Yeah. So 3 minutes from now. All right.
Okay. So we finished with this case, and I have to, I will show you a series of clinical cases to illustrate this technique. This is a case with 3 extractions to be done here in the anterior region. And we have good bone, but we have defect. We expect a defect in the anterior around the root of the central and lateral incisor. The treatment plan is the extraction of the 3 roots, which cannot be recuperated, and the implant here in the lateral zone and on the both laterals, and to have a bridge of 4 units bridge without putting implants in the central incisors. So the first steps are the extraction of, as you see, fractured roots. Very nice curtage of the alveoles of the socket. And I usually do irrigation, debridement of cleaning of the sockets with a mixture of 50% iodide solution with 50% saline solution. It allows me to clean very nicely the socket. As you see here, what we have in after curtage of the which is very important. After extraction, you have very large defects all around these extracted roots. In classical cases, you don't have to do anything about this, not implant, because if you cannot deal with GBR or harvesting bone, it can be very difficult to put implants in this case. But as I explained before, if you do the zero bone loss technique, you can do your drilling with the trephine burr here in the 2 lateral incisors. The implants are inserted and, sorry, missed too fast. And the bone harvested from the drilling is put in the vestibular zone on both sides of the implant. The implanted zones. And this is the X-rays. This is the X-rays after implantation, and of course, in this case, you must not load your implants and you must recover the implants for a second stage surgery that can take place after 3 months of healing. This is 3 months of healing here. As you see, very nice results, no recession here. This is the first bridge we made. As you see, no problem with the gum, no problem with the implant. The smile of the patient was very, very happy, and as you see, no recession about the lateral incisors. Another case where the canine and the second premolar were to be extracted. You see, they're very bad roots. This is a nice case where there's no bone loss here. I didn't raise a flap because there is enough bone, but even if you have enough bone here, we do the trephine burr. It can give you the carrots here, you recuperate, and this is the image that shows the axis, the normal axis of the root, and the new axis of the socket we made for the implant. This is the parallel pin to see the direction, the good direction of the implant. After implant insertion, as you see, 1 to 2 millimeters below the bone, and those are the carrots that we insert between the implant and the buccal bone. This is a one-stage surgery. The healing abutments are screwed in place, and you have a special sutures that I advise you to do. This is a crossed sutures you have to suture in order to I don't know the word in English, to best cover the gingiva around the healing abutment. I usually do a co-pack. This is a periodontal pack around the implant. This prevents in cases you have patients who can show on this side with this pack done. This is a co-pack, normal co-pack we do in periodontology. I do it here to protect the implant site from showing, and it gives a good healing. The X-ray after insertion and the healing process after 3 months, 2 or 3 months of healing. Very nice healing. And you must want inserted very palatally. You leave enough space, enough thickness of bone and gingiva in the buccal aspect. This is a young patient who have a genesis of both laterals and canine tooth, when she underwent orthodontic treatment to enlarge the space for the lateral, but the orthodontist didn't succeed to do this, and he sent me the patient to do the extraction of the canine. As you see, the canine are between the lateral site and the canine site. This is a very interesting case for this technique, because as you see here, this is the image of the temporary canine that must be extracted here, and after extraction, the socket is not suitable. It's not a good site for putting an implant immediately. If you do the normal drilling, it is very difficult to have a very nice axis. The objective, the goal of the drilling here is to create a new alveolar socket here, 3 millimeters majorly to the first premolar, and as you see here, the distal bone can be a very harmful to the insertion of the implant. If you don't do this technique, the bone that is very strong here in distally will push the implant toward the socket of the extraction. Those are the implants in the correct site of the canine, the direction of the canine, and then the gap between the newly formed socket and the extraction is filled with the bone harvested from the trephine Burr. You see there's no gap left, and the case is allowed to heal for 2 to 3 months healing. This is a special technique for suturing. We cross the points of the sutures. You take mesially and distal papilla, and you suture them. This is an X, what we call X sutures. 3 months healing. This is before, at the time of insertion, and 3 months later, the gap of bone is healed and is filled with the bone of the patient. This is an autograft. I finish with this. We'll finish with this case, which is a very complicated case that needed a graft. This is a female patient which had a bridge that with fracture of the abutments here, the roots for the central incisor and the lateral incisor. The bridge, the roots had to be extracted, and the temporary RPD was put for the patient, and then it was planned to, this is the panoramic X-ray, it was planned to extract all these teeth and to put implants. You don't see here in the panoramic, but you have a canine, the canine was, which was enclaved in place. As you see here in the panoramic X-ray, you have the canine that that does not allow us to do drilling. This is the drilling. During the drilling, the canine does not permit us to put implant. So the treatment plan was to extract this teeth and to extract the canine tooth. Let's go through the X-rays, the CT scan. This is very narrow crest here, and the central incisor, and you have the canine that goes from the premolar region to the central region. We cannot put any implant in this site, and the canine must be extracted. Had to be extracted. These are details of the CT scan. We have the apex of the canine, a very large canine here. This is after extraction, very narrow ridge, the very narrow bone here, dehiscences, and after extraction of the canine, a very huge defect. If you can discuss this case, if you leave this case with healing, normal healing, after 4 or 6 months, when you will go to a procedure for putting implants, you will have no bone, because most of the bone will resolve, and the immediate implantation here with grafting will do a very nice result and will preserve a maximum bone for the patient. Sorry, went too fast. This is an allograft. This is a bone from a bank. This is a human bone that is prepared, that we prepare for the to graft this site, this huge site of the canine left by the canine, and the buccal aspect here in the central incisor. The bone is cut, and we have here a gabarit. What you call a gabarit? This is a sterile paper to have the right dimension, to choose the right dimension of the bone that we cut here with piezo surgery, and we trim it in order to put it right in the defect. This is the bone that will be fixed with the screws. This is the procedure for fixing the bone here, and another part of bone that is fixed on the buccal aspect of the central incisors. Besides of this, 2 implants were already inserted, as you see in the
Allah? Yes.
Yes. Yes.
I think, yeah. Solution.
Sorry. Wait, what's your question? I don't hear you.
Sorry, Prof. You can proceed. You can go ahead.
Okay, I had I thought I had a question from someone. So this is the grafts done. I was telling that besides the graft, the 2 implants were inserted in the canine sites for the right and the left canine. This is the right one, and the left canine here at the same time of the grafts. The grafts fixed with pins and allografts, with mixture with allografts and xenografts to develop fill the gaps between the grafts and the socket. Of course, we leave this to heal for 6 months, at least 6 months, and this is the X-ray immediately after insertion of the 2 implants after extraction. As you see in there is no more socket for the canine that was extracted. And those are the screws that fix the graft. After healing, this is the X-ray, where we see a very nice bone formation in the around the graft. I go fast and okay. And this is 4 months later, a very nice result with formed bone here. As you see, after raising a flap, we unscrew the osteosynthesis screws, and we have a very nice bone formed around these large defects that allow us to put 2 implants in the central region, 2 implants here, and the treatment plan is to put 2 bridges from 3-unit bridges here laterally on the right and the left side. This is the second stage surgery. We have the 4 implants done here, and after healing of the implant, there was no bone loss here, with 0 bone loss for the patient, and we prevented a very large defect that saved a lot of time, because the whole procedure took 6 months from the beginning of the extraction to the healing process. If you don't do this technique and wait for the healing, you must wait at least 6 months and do the surgery for grafting, and then take another 6 months for healing, 6 to 9 months for healing, and then do the implants. It takes 3 months for healing the implants. That is at least 1 year and a half to have such results. In this case, it took 6 months of healing. Do we have enough time to talk about the premolar region and the molar region? So I ask you if I will continue. I think we have enough time. I started with the anterior region, but now we are dealing with the posterior region, and will give you some tips only, some guidelines to do immediate implantation in the posterior region. As I showed before, a case of implantation in the premolar region. It is very obvious but I must say that as I saw very bad cases, very pitfall, very frequently encountered cases with very bad implantations, either buccally or palatally in the premolar region and the molar region. You have very big problems with that. If you have to implant in the premolar region, you must choose between the two roots. This is to illustrate the implant must be put here. It is very difficult to do normal drilling between the two sockets, because once you want to drill, the drills go either vestibulally, buccally, or palatally. With the trephine burr I showed you in this lecture, you do a newly formed socket just in the middle, and you can insert your implant, and you recover the carots of bone. You put them in the vestibular socket and the palatal socket. This is the case I showed before. The implant is put here. As you see, if you don't raise the flap, in this case, you will have a defect that you don't see, and you have a very bad aesthetic result. You may lose your implant. With the recovery of the carrot, you see the carrot is put in the vestibular aspect, and then the patient doesn't need any more grafts with that. You see, it fits very well in this vestibular socket of the premolar, and the implant is put in the mesiodistally between the two roots. This is for the extraction. You must prefer the root section to extract each root individually, in order not to break, to damage the bone around the implant, around the future implant. This is a case I had in my practice, done by a colleague in Casablanca, and he did the mistake by putting the implant without raising a flap, and the implant was pushed forward, pushed toward the vestibular bone by the middle of the bone between the two implants. This is another case where the implant was put, it was inserted in the palatal socket of the premolar. This is very bad for hygiene, and the patient was complaining about soreness here and constant bleeding of the gum here. Now, As you see, the implant must be inserted in the middle between the two sockets. This is the case where the implant was disinserted with unscrewed, and there was another extraction of the premolar. This is the implant, or where the bad implant. When we extract the implant, we have a very large defect here left by the implant. This is the newly put implant here, and you see the traces, the print of the threads of the ancient implant here. The implant was put just in the middle. We don't need anything here. Don't need no. And this is the bone recovered during the drilling, and it was intended. It was used to fill the gap vestibule. This is after healing, 3 months healing, very nice healing with no bone loss in buccally. This is another case. You see, with the implant inserted buccally. This is what I explained in the beginning of my lecture. The implant, when inserted without raising the flap, when we were at the time of insertion of the implant is pushed forward toward the weakest part of the socket, and it is vestibule here. It is very difficult for, especially for beginners, to get a new axis between the two roots, the vestibular and the palatal root. That's why I advise you to use this technique with the trephine burr. It gets you a new socket, and the defect will be filled with here with xenograft and collagen membrane, and it's allowed for healing to immediately. You see, after extraction of the implant, the other implant is inserted. We don't need to wait for healing of this implant. In the molar region, those are very old slides, maybe 15 years slides. When I used to use a wide implant, this is a wide implant of 5.5 millimeters. I don't advise you to use wide implants. The widest implant I use now is not more than 4.2 millimeters in any situation, even in the molar region. It is very sufficient for supporting crowns in the molar region. A wide implant takes too much place and doesn't leave you enough bone, enough gum around, and especially in the vestibular region. This is the implant put right in the middle between the three sockets here, the vestibular sockets here and the palatal socket, and the implant here. This is a one-stage surgery. After healing, this is a 3 months healing, 2 to 3 months healing. I don't remember. And this is the healing process. The implants are inserted. This is in the premolar region, in the middle for the. This is another case where the two. You see here 4 sockets. This is the normal sockets after extraction, and the newly formed sockets in the middle of the 3 sockets here, where the implant is inserted. This is the extraction, the molar, the upper molar, the 3 roots, and it is put in the middle of the 3 extraction. And what we recovered, harvested during the drilling and the trepanning of the bone, we put it in the alveoli, and you don't need any more grafts. This is another case where multiple extractions are made. This is the canine, premolar, and molars. Same technique. The implant in the lateral incisor, in the premolar incisor, and in the middle of the molar incisor. You see, I had enough bone stability, and the recovered bone was put in the gaps. With the gaps were filled with the bone recovered during trepanning, because I had 3 carats of bone here that I used to fill the gaps between the implants. This is was a mediate loading here. The immediate loading at the same day, say with the provisional resin bridge, 15 days after healing, and 3 months after healing with the temporary bridge. You see no bone loss here, no recession. This is the case in 2009, and at the control visit 5 years later. This is a very nice case, no problem with healing. Another case I show you with extractions of the premolar and the molar here, the bridge that was extracted. You see with apical infections. I don't advise you to do this procedure with apical infection unless you have a large experience with that. Those are the implants. It's a very old case. This is the wide implants. I don't use no more wide implants now. You see the results here, and sorry, a few months after insertion, the implant is here in the molar. This is a 10 years follow-up. This is a very nice case with preservation of gum and bone after extraction. And in the mandibular molar, you put the implant right in the middle between the two roots, the distal and the mesial roots. With the same technique, you do the trepanning of the middle, the septum, the septa, the bone septa here, that you recover, and you put it mesially and distally around the implant. If you have nice primary, good primary stability, you can do one-stage surgery. If you don't have primary bone stability, you do a two-stage surgery. This is another case with extraction of the I'm sorry, the X-ray is inverted here. The implant put and the sockets are filled with bone recovered, harvested from the patient with the same technique. Another case, premolar here. The implant is inserted, and you see the bone that was harvested filled the sockets. Is another question here. Is the chronic infection a contraindication to immediate implants? In literature, it is. When you have apical infection around tooth, you shouldn't do implants unless you are skilled or experienced to do that. I will show you a case with extraction of this is a lower case, a lower incisor bridge that was with roots that was decayed and fractured. As you see in the X-rays, there was a narrow bone here around the roots. This is a case I done maybe 15 years ago. Extractions, implants inserted in the canine region. You don't have, this is the occasion for me to say that for the replacement of a 6 Younès bridge, bridge in the anterior region, in the lower maxilla, you don't need more than 2 implants. You put 2 implants in the canine, that is sufficient to have a 6 Younès bridge here. This is before and after the insertion of the bridge, and this is the case 13 years after extraction, after insertion of the bridge, a good preservation of bone and gum. I will go fast through this case and show this I will show you this last case. This is a case that came to the office with a bridge. This is the panoramic of the patient. The patient came with this X-ray. When I asked the patient what was the history of the site here, she told me that she had a very old bridge with infection around the premolar root. Okay. This is 9 months earlier. She had a bridge with a very large infection, cystic infection. When I do the X-ray, I saw that the bone was healed, and I thought I could put the implant here without raising a flap. At the moment of drilling, I had some pus going through the hole of the, as you see, and there was a large infection here with xenograft bone that did not heal, and I realized then that the practitioner, the dentist before me, didn't clean thoroughly this alveoli, because there was the nerve, the mental nerve here, and he was afraid to tear the mental nerve. I don't have the surgery here. I did a flap and then cleaned very well the defect that was here, and then put 2 implants here after a good cleaning. I must stress the good cleaning, and you see here after 3 or 4 months healing, a very nice healing around the implant. That is to say, this is the clinical case after this is the premolar and the molar that was replaced in this case. And through this case, I show you that even if you have infection, you can do immediate implant at the condition that you must clean and have a very nice site of the surgical site, not leaving anything that is bad tissues in the site of surgery. That's all. I come to the end of my lecture. I thank you for your attention, and I'm ready for your questions. Hello?
Thank you very much, Prof, for such a nice presentation and captivating cases. We really appreciate. We have a question here. Good evening. Thank you for the lecture. What are your thoughts on partial extraction therapies for immediate implant placement? The literature suggests that this would be better for buccal ridge preservation, especially in the aesthetic zone. That's a question directed to you, Prof.
Excuse me, I didn't understand the catch. The first question.
The first question was, what are your thoughts on partial extraction therapies?
Partial, I don't know what is partial.
Those treatments, the socket shielding technique,
Socket shield.
where, yeah.
Hmm.
So they're saying, what's your thoughts on that one?
Yes, I usually have this question when I finish my lecture about the implantics. Myself, I don't practice this socket shield technique. It can, in most of the cases you saw in my lecture, there was no case that could be managed with this technique, because this technique, for this technique, you need to have the type 1 sockets. That means that you don't have any fracture of the roots. You have a nice roots, healed root, no problem with the roots, and you leave a shield, you leave the buccal dentin of the roots buccally, and you put your implant palatally. And in most cases I deal with, I don't have the opportunity to do that. But as I saw in some lectures, it can be very helpful and have good results. But myself, I don't have enough experience for this technique. I cannot answer correctly this question.
Okay, thank you, Prof. Any more questions, colleagues? Anyone with any question for Prof? This was a very nice lecture. I really enjoyed it.
Thank you.
There is a question here. Your anterior immediate implant with the 0 bone loss using trephine. With that inclination, do you use cement or a screw? That means on the final prosthesis.
That is the prosthetic aspect of the treatment. You can use either cementation or screwing, but with this technique, as you incline you can do new axis. It allows you more to do screw retained bridges or crowns, because your axis is very palatal and you have enough space to do your screwing. As you know, in the anterior region, most of the cases are very inclined vestibular-buccally, and it is very difficult to have cases with the axis screw in the palatally very easily. But you can do it. It is not. It is dependent on the way you do your prosthesis. You can screw or cement your crowns as you want.
Oh, okay. Thank you. Another question. This one is, this doctor is asking your thoughts or your experience with guided implant surgery compared to the freehand surgery. What's your experience? This one, the technique, compared with guided surgery?
Yes, I understood the question. In my practice, I do only freehand surgery, even in the most complicated cases, because I have a large experience with that. But I also teach my students, my fellow colleagues, even experienced one, to do guided bone surgery with surgical guides. It is very helpful, especially for beginners, to do this. And you can plan it even when in the case of immediate implants, because it will give you really the complete control of putting the implant in the right site and the right depth to achieve very good aesthetics. I advise you to do such guided surgery. It's very helpful. It is less difficult than doing it freehand.
Oh, thank you very much, Prof. You have actually answered the next question again, which was asking about 3D planned flapless implant surgery and stand guide. So you have
Flapless.
actually answered.
With flap, this is another aspect. The flap, doing a flap or not doing a flap, it depends. It is very technique sensitive. It is operator dependent. If you have a very experienced, you can do without raising a flap. But as you saw in most of the cases you saw in my presentation, there was, I am very experienced in implantology, and in most cases, I do a flap, because in the anterior region, as I said in the beginning, you have very thin walls, very frequent dehiscence and fenestrations, and then you don't see that when you don't raise a flap. And in the case of infections, as I showed in the last cases, you are not very sure to have cleaned thoroughly your sockets. So it is advised to raise a flap. But if you do it with guided surgery, you can before putting your surgical guide, you must be sure that you have cleaned and you have no defects in buccally before putting in your implants. And it comes with experience. And if you have enough experience, you can do a guided surgery without raising a flap. That is my opinion.
Okay, thank you very much. Maybe the last question. Excellent lecture, Prof. What is better, a resorbable membrane versus using a titanium membrane?
Okay. As you know, there are resorbable membranes that resorb for about 4 months, and non-resorbable membranes with titanium reinforcement that you need to have a second stage surgery to extract, to enlever. And then in this case, in most of the cases you saw, I do the resorbable membrane, because I don't need for these cases, as you do the implant immediately after the extraction. You don't need to do with this technique, the zero bone loss technique, a non-resorbable membrane. As you saw in the last case where I did the graft, maybe I could have a more good result if I did non-resorbable membrane, but I didn't do that because in Morocco we didn't have non-resorbable membrane available at this time. For answering your question, it is better to do in this case, in the case of immediate implants, non-resorbable membranes done with the technique of the sausage technique, as I saw in the video, with pins fixing the collagen resorbable membranes.
All right. Thank you very much, Prof. We appreciate the lecture. It was very interesting, and the colleagues here are appreciating it very much. It was an excellent lecture. Thank you very much for being with us.
I thank you very much, and thank the organizing committee of the Zimbabwe committee of the Zimbabwe dental meeting. I hope that one day I can visit your country. How many dentists are you in Zimbabwe?
Around 250, I think.
Okay. Okay. Do you have dental school in Zimbabwe?
Yes, we do have a dental school.
One or more?
So far, only one.
Only one. Okay. Okay. Thank you very much. It was an honor for me and a pleasure to lecture for you. Thank you very much.
Thank you. Bye-bye. Have a good day.
Have a good day.
Thank you, Prof.
Thank you very
Thank
much,
you.
Doctor.
Thank you.
Bye. Have a good day.
Have a good day too. Have a good day too. Thank you very much.
Thank you.